Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. Eating disorders are psychiatric illnesses that affect approximately 30 million children, adolescents, and adults in the United States. Eating disorders are not just about weight, but often have to do with the way that people cope with emotional issues. Robert Wood Johnson University Hospital, Somerset, is only one of two hospitals in New Jersey to offer inpatient care for the treatment of eating disorders. On today's show, we will learn about the different types of eating disorders, common signs and symptoms, and different treatment options for adolescents and adults who may be struggling. We are pleased to welcome Frank Gianassi, Senior Vice President, Behavioral Health at RWJBH and President and Chief Executive Officer of Rutgers Health University Behavioral Health Care. We are also joined by Linda Mullen, Clinical Director of the Eating Disorders Unit at Robert Wood Johnson University Hospital, Somerset. Welcome to the show. Thank you both for being here. And for the audience, they'd like to know a little bit about your background. So we'll start with Dr. Gianassi. Can you tell us a little bit about yourself, your background, and what you're currently doing at RWJBarnabas Health?
Absolutely. It's Frank Gianassi. I'm a clinical psychologist by training. I've been in the field for decades now. My background has been in both clinical research and training. I've worked at two other academic institutions. I was a decade in Boston at McLean, which is part of the Harvard Medical School system. And then I spent a couple of decades at the University of Pittsburgh Medical Center, where I had similar clinical administrative roles. Currently, I serve as the Senior Vice President for the Behavioral Health and Addiction Service Line across RWJBarnabas Health. And I also serve as the President and CEO of Rutgers University Behavioral Health Care, which is also a statewide delivery system of behavioral health addiction training and research. And I'm thrilled to be here. Thank you.
And Linda Mullen, can you tell us a little bit about your background and what got you into also being part of the eating disorder unit at Robert Wood Johnson University Hospital, Somerset?
Thank you. My expertise is in eating disorders and a history of trauma. I'm the clinical director of the eating disorder inpatient and outpatient units. I've been in the eating disorder world for a better period of 10 years. And I came to RWJ upon an opportunity that was offered to come into this newly developed unit and expand it into the general areas of the community.
Thank you very much. Thank you both for being here. Now, what we'd like the audience to understand is what actually is an eating disorder. Either of you two can talk about it.
Well, there's a range of, it's a category, and it is characterized really by a relationship with eating and food. It very often involves body image. It can involve histories, as was pointed out by Linda, of trauma. It can manifest itself in a variety of ways. For many, it can involve restricting, both in terms of quantity of food or type of food. As a cluster, those are often referred to as anorexia. Anorexia disorders carry a broad range of both psychological and physical health risks. Matter of fact, it's the highest risk in terms of suicide and morbidity and mortality, actually. There are other forms of it, which can include bulimia, which is eating large quantities and then purging, and that has its own lifestyle and cycle. And then it can include a broad range of disorders where individuals go through periods of fasting and weight gaining, and there is a disorganized and disordered relationship with food. It affects roughly 9% of the population. It's estimated that in the US, that's about 28 million people. It can start as early as age 5. While it is more commonly diagnosed in Caucasian populations, it's believed that it is underdiagnosed in individuals of color across the country, and we're continuing to try to find ways to better screen for that. It affects females, at least in much of the literature. Females seem to be affected about twice as often, although again, we believe that may be underrepresented case finding. It is the second leading cause of death among behavioral health disorders, secondary only to opioid addiction. Most recent figures indicate that somewhere around 10,000 people a year succumb to this disorder, either through suicide or other medical disorders. So it's a substantially prevalent and very real and pressing disorder.
And how exactly is one to diagnose these?
Linda?
Sure. Eating disorders are complex. So because of this, we typically do a comprehensive assessment, and that'll include a complete medical history, a physical, lab work. We do a complete psychological and nutritional evaluation. And upon doing so, we'll utilize a standard diagnostic criteria to determine the specific disorder and its severity.
Thank you. And, you know, in this world with all of the stress, et cetera, going on, is it true that we're seeing an increase in eating disorders in adolescents?
Yeah, you know, it's interesting. So when you look at trends, going back to 2000, the most recent data I looked at just yesterday, knowing we were going to be talking today. And in 2000, global prevalence was sitting at about 3.5%. That number over the last 20 years, most recent was around 2022. It has gone from 3.5% global prevalence to over 7%, 7.4 actually. Which means that it has more than doubled over the last 2 decades. Heavily affected in that are younger individuals. We believe a lot of that's related to the 4 or 5 years of stress caused by COVID. There are some indications that perhaps social media drives some of this with a image-conscious society. And there is also growing evidence that the LGBTQ and transgender population are even more impacted than some other populations.
And are they, you know, again, they are considered extremely serious conditions, and some even can lead to life-threatening illnesses. Is that true?
Linda?
Yes, it is very true. The medical reasons behind that, I'll leave that up to Dr. G to answer.
Yeah, so the mortality and morbidity happen in a variety of different ways. And you're right, it is the second most lethal behavioral health or addiction disorder, again, only behind opioid. Suicide plays a large role in that. Of the subtypes, anorexia, bulimia, problem, disorganized eating, highly specialized eating, anorexia drives a lot of that mortality and morbidity. That comes in a number of ways. Self-harm is one. The other is that at very low body weights, below 80%, 75%, you can begin to see muscle deterioration as the body begins to actually consume its own muscle tissue. Also, if that restricting involves fluid levels, you can see electrolyte imbalances, which can affect cardiac rhythm and cardiac arrhythmia, which can itself drive both mortality and morbidity. So there's a number of ways. Bulimia, again, is a very, very difficult on the body. There are periods of purging and binging that can affect a variety of system disorders, including dehydration. And just the weight gain and weight loss has metabolic impacts on individuals. So mortality and morbidity in this disorder is very high.
So what are the common symptoms that one should be aware of as either a parent, a friend, a relative, a physician, to start looking at whether a person has eating disorders?
Linda?
Sure. While each of the disorders has its specific telltale signs, the red flags that span across most of the eating disorders, if not all, would be significant weight fluctuations, be it trending up or down. It would be food rituals, food rules. It can be cold intolerance and secretive eating habits, amongst a few other things.
And what are the types of eating disorders that are treated at RWJ University Hospital, Somerset?
We treat each of the classified eating disorders. So for purpose, it would be anorexia, it would be bulimia, binge eating disorder, ARFID, which is avoidant restrictive intake disorder, and OSFED, which is other specified eating or feeding disorders.
Now, since there's a whole spectrum of what an eating disorder is, does RWJUH Somerset have different treatment levels offered for patients?
We do. We have inpatient hospitalization, partial hospitalization, and intensive outpatient levels of care.
And can you describe what each one is about?
So individuals who will require 24-hour medical monitoring and observation would be appropriate for our inpatient level of care. The goal for this level of care would be medical stabilization, treating the acute symptomology, and patient safety. It is our most intense and restrictive form of treatment. Individuals who are medically stable yet may still require a structured setting and additional programming would be appropriate for our partial hospitalization programming, while an intensive level of care best suits individuals who are in need of more support than our traditional outpatient, which is once a week, and can benefit from services while also maintaining their daily life.
Individuals can also sometimes, depending on their weight, can also benefit from psychopharmacologic interventions, which can include medications to deal with depression. So there are antidepressant options. There are medications that can help with some of the anxiety that's associated with it, although the goal is to really use interventions that are more psychosocial, like cognitive behavioral therapy, to assist with anxiety, mindfulness and dialectical behavioral therapy to deal with affect and emotional tolerance. Other medications are sometimes helpful in this process, can include medications that help with rumination or thinking that becomes obsessional. But again, those medications are used in conjunction with psychosocial interventions. And below a certain body weight, many of those medications are not terribly effective. So it's really very important, both in terms of mortality, morbidity, and overall recovery, to get individuals back up above sort of 85% ideal body weight and higher if possible.
And as you know, RWJ University Hospital in Somerset is only one of 2 hospitals in New Jersey that actually offer inpatient care for the treatment of eating disorders. So tell us, how long do patients usually stay if they're inpatient, if they're partial hospitalization, if they're IOP? Is it very similar to how it would be with addiction to other type of addictive programs?
It's based on individual needs and severity of treatment and their progress. Inpatient can range from a few weeks to a few months, again, with the goal of being stabilizing their medical conditions and addressing those acute symptoms and ensuring safety. Partial hospitalization can range anywhere from 45 to 90 days with the goal of providing that structured support. They attend 5 days a week for 5 hours a day. And again, they get to go home at night. While our intensive outpatient population typically ranges anywhere between 30 and 90 days as they continue to maintain that progress and develop a relapse prevention plan.
And can you also describe what the multidisciplinary team is that is in the unit as well as in the outpatient programs?
Sure, they utilize the same treatment team with exception for nursing. So our inpatient team consists of psychiatrists, nurses, dietitians, psychotherapists, and some adjunct disciplines, which include our occupational therapists, music, drama, and rec therapies. Again, our outpatient team is similar without the nursing care.
Now, is there something special about the inpatient unit? I've heard there's something about the color scheme in the inpatient unit. Can you tell us a little bit about that and how that also contributes to the improvement in the patients?
So, I've actually seen Dr. G give a presentation regarding our inpatient unit and the design of it. Dr. G, would you like to take that, or would you like me to answer that?
Yeah, no, why don't I start, Linda, and then you can join in. So the unit really has been designed to serve as a calming influence. The colors tend to be muted. They're light-colored pastels. There is an ingenious utilization of indirect lighting that permeates the building, where the lighting is not direct fluorescent or bulb. It also varies with the time of day, and it varies by color. So as the day moves throughout, the color of the lighting shifts a little bit. A lot of that was based on ergonomic principles around biocircadian rhythms. It really is a very, very sophisticated environment. There are communal areas where people can join together and discuss daily events, really relax together. And those are very conducive. And yet at the same time, it allows for refuge by going back to their room when they need more quiet or less stimulating times. Many psychiatric units, unfortunately, are retrofitted from former med-surg units where patients really spend all of their time typically in their bed because of a medical problem. And then when you retrofit that to the psychiatric unit, it never quite has the right spacing and tempo. This unit was specifically designed for eating disorders. There's common space areas. The lighting is really designed not for medical procedures, but for ease. And so the design is unique, and I think literally one of the active ingredients of the recovery process. Linda?
It's a beautiful facility.
And can you tell us, I've heard also that that the unit is separated into two different units, one for adolescent and one for adults. Can you tell us a little bit why it's like that, and is there differences between treatments between the two?
Linda?
Sure. So yes, we have a 20-bed unit. It's separated into two sides. The adolescent side is 10 beds and the adult side is 10 beds. We provide age-appropriate and developmentally appropriate treatment to each population, and there are some state regulations that require us to keep our individual populations separate.
And the treatment it's basically geared towards the age appropriateness of the patient?
Yes.
And the color scheme, et cetera, all the same?
Identical. Both sides of the unit are identical in appearance, just the age is the difference.
There's also an opportunity, unlike a traditional med-surg hospital where eating takes place on trays, usually at a bedside table, for again, a medically impacted individual. These units have communal eating, and that is itself part of the treatment process. For many individuals with eating disorders, as Linda had mentioned, there's a secretive nature to their relationship with food, and it often involves shame and anxiety. This communal eating with assistance from therapeutic unit staff allows individuals to desensitize some of that anxiety, to begin to re-normalize eating patterns, and to learn to do what most of us do day in and day out, which is to eat in social settings. and to do that in a way that doesn't involve shame or guilt or anxiety. So the actual eating process itself is another component of the treatment normalization.
Resources. Do you provide resources for the family or friends of those who may be struggling with eating disorders?
We connect each individual with community resources, and for families who are seeking to do additional research on their own, we often refer them to the National Alliance of Eating Disorders or the Eating Disorder Association. At our hospital, we do have 2 support groups that run in the evenings to support families.
I'm a internal medicine physician, so primary care, and I've got lots of colleagues who are family physicians. We're seeing a patient in the office that we suspect may have an eating disorder. And it's more than we can handle. What is the process that a physician or even a family member would have in order to get them involved in the eating disorder center that's part of RWJBH?
We have what we call access line, which is an 800 number to the hospital in which an individual can inquire about receiving an assessment with us. We perform comprehensive assessments 5 days a week, and then we will make the appropriate referral for care.
So I would, as an internist, I suspect possibly someone has anorexia or possibly the opposite, they've got bulimia. And again, as I said, it's too much that I, as a primary care, that I can do. And since I do need a multidisciplinary approach with people such as a psychologist, possibly psychiatrist, an eating disorder, the best thing would be to access the access line.
Absolutely. And if there was a doctor consult that you would like to have, you can call the unit directly and we would put you in touch with the appropriate individual.
Which again, good to know. I'm sorry.
I really would encourage you, doctor, to tell colleagues, and I know we're doing it with this, to err on the side of conservatism so that if they have a suspicion that something may be awry, it's probably better to trust that instinct and to reach out for a consult and or even an evaluation. These things can be very difficult to discern early on, and very often early in the process, whether it's an adolescent or an adult, there may be many rationalizations that the individual offers in trying to normalize this, and they will offer those as part of the very disease process, not yet having identified that there is an issue. So if a physician suspects that something may be awry, we always ask that you seek consult and reach out. We're happy to be of assistance.
Again, like a cardiologist, I need to consult you when I can suspect that possibly is an eating disorder, because again, the eating disorder could lead to serious complications, serious illnesses, such as cardiac illness, GI illnesses. So your consult is just as important as the cardiologist consult or the gastroenterology consult.
We agree.
Any last thoughts before we close the show?
Linda?
I think that the thing I would like to emphasize is something that Dr. G touched upon, and that was really, we offer a full spectrum of services. We have medical monitoring, medication management. We offer individual and group therapies, family therapy. So it's very comprehensive, and we have a terrific treatment team here. We're very highly skilled, very empathic, and we really enjoy helping individuals with their recovery journey.
And I just want to emphasize too that, health is an academic medical center system. And what that means is that they have been willing to tackle the more difficult and complex disorders, both in physical healthcare and also in behavioral healthcare. So the fact that they are one of 2 units in the state, in many ways, offer a leading model for care for this is just further evidence of the benefits of academic medical center systems. We also use this unit to train the next generation of healthcare providers in nursing and psychiatry and nutrition and other areas And it also offers opportunities across our academic partners at Rutgers to engage in research and help advance the science. It really does provide for the entire package, and we're really glad that RWJBarnabas Health is taking on this population. It's terrific.
Thank you, Dr. G, and thank you, Linda, for being here and for educating our public on how important eating disorders are.
Thank you.
Thank you.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about RWJBarnabas Health's Eating Disorders Services, please visit www.rwjbh.org/eating disorders.